Tell me some of the common myths that we see with lip filler.
You look on TikTok, you look on Instagram, everyone's like, if I get lip filler, it's going to migrate. That's the biggest one.
What is a lip lift? Who's a good candidate?
For those who are not familiar, the surgical lip lift is the surgical shortening of the lip. When a lip becomes longer over time, starts to cover the teeth, you start to lose some of that red lip show. These are all things that would make somebody a good candidate for a surgical lip lift.
Tell me a little bit about some of the things you look at. Let's say a patient that comes in for lip filler.
Personally, I'm not a big ratio, like the top lip has to be 60% and the bottom has to be 40. That's never been my jam. I think I like to just kind of work with what someone has naturally.
There's really 4 things that I look at that says this is a beautiful lip. Definition, volume, and we'll talk about that in moderation, the amount of lip show or pout. And then the last thing that we'll discuss a little bit when we just talk about the anatomy is proportion. Hello, everyone, and welcome back to your favorite podcast, Beauty in Bloom. As always, I'm here with my nurses. We have Sarah Hutchins and Lilly Marquez. But instead of Simone Talmore, we have a very special guest on this episode. And that special guest is my partner, Dr. Julie Shtraks.
Thank you for having me.
So it's great to have her specifically on this episode because this episode is really cool because we're talking all about lips. Mm-hmm. And we're going to talk about, lip filler, neuromodulators around the lips, and certainly, the lip queen over here in our practice who Dr. Shtraks does all the lip lifts and why it's a great procedure on the right patients, and she's going to talk a little bit about that. So with that, I think it's important to discuss a little bit of the anatomy for the lips. And I like to say, just in general, when I'm looking at a set of lips, there's really 4 things that I look at that says this is a beautiful lip. And those 4 things are, first of all, definition. Mm-hmm. So I look at the lip border, and I think a sharp border to the lip brings a lot of definition. And when you have that sharper border, it kind of stands out better from the rest of the mouth. The second thing is volume, and we'll talk about that in moderation. What's the appropriate amount of volume? But I think that is important to a beautiful lip. If it's under volumized, it looks maybe a little bit weird. If it's over volumized, certainly looks weird in those situations. Another thing is the amount of lip show or pout, right? How much roll you have to the lip, how much red lip is showing. And I think you can improve that with both filler and neuromodulators, the so-called lip flip, which we'll talk about, and also lip lifts. And then the last thing that we'll discuss a little bit when we just talk about the anatomy is proportion. And proportion is different. Different ethnicities have different proportions to the lip, and I think that's important. And also just the general population has changed what they think is beautiful in even a Caucasian lip. So we'll go into some of that. So let's start. Sarah, tell me a little bit about some of the things you look at when you're evaluating a patient, let's say a patient that comes in for lip filler.
The most important thing is it appropriate? So do they, not only do they want it, but do they need it? And is it appropriate to do on said patient? So if someone comes in and they've never had it before, 9.9 times out of 10, it's usually appropriate to me if they want it. The issue is people who are coming in who have been fired from another practice for abusing the right to lip filler, and then they come to us and It's like, oh, I've never had it before. And they so obviously have had it multiple times. So, I mean, I'm not a big ratio, like the top lip has to be 60% and the bottom has to be 40. That's never been my jam. I think I like to just kind of work with what someone has naturally. I think that looks better than chasing these ratios. I think that's when someone kind of looks distorted and strange, in my opinion. So, I mean, I think most people who want a little bit of lip filler are usually, I mean, if someone has a really long, if someone has a long distance between the base of their nose and the top of their lip, I try to steer that person away and send them to Dr. Shtraks, just because weight in the lip, even if it is just a little bit of filler, will elongate that space. And actually, you have pictures of patients who you've dissolved and you've taken before and afters of when they have the lip filler versus after it's dissolved, excuse me. And it makes a huge difference, just the dissolving. Totally. So, and I always reference that when I'm talking to patients about the weight, that just even a little bit of filler can weigh the top lip down. So sorry, that was kind of a long answer. But
no, I mean, listen, so that makes sense that, the patient has to want it, but they also need to be a good candidate. And we're certainly not just giving everyone in the, that comes in the door lip filler that wants it. But Lilly, we all see some of these things that change, both anatomically and functionally with age. But tell me about what happens to the lip as we get older.
So you see with older patients, they have a lot of volume loss. And then you notice that they have elongation of the upper lip, and their upper lip tends to curl under. So when they smile, they're kind of seeing more skin than the pink of their lip. And that's a big issue with a lot of the older patients. They say, oh, I used to have a lot fuller lips when I was younger. So they're kind of chasing that. And you really have to set an expectation, because they do lose a definition in the vermilion border as well. So if you notice a patient that has from the base of the nose to the upper lip is a lot longer, I probably would refer them to Dr. Shtraks, because you can add filler in there, but you also need to kind of lift the lip as well and show a little bit more of the pink. If you just notice some volume loss, you definitely can fill it with a softer filler, just to kind of make them look a little bit more hydrated. But you definitely have to set expectations with older patients, because they don't have that volume anymore, and they don't really have that lip space to fill.
Yeah, and so, we're not just losing volume actually in the lips, but you're also losing some of the support, actually muscular support that goes along. One of the things that I see most, and I personally hate injecting lips, so I send all my lip filler patients to you guys. But one of the things that I do see a lot in my patients is patients with perioral rhytids, right? So they're talking, kissing, chewing, smiling. They're moving their lips a lot. They're getting a lot of rhytids or wrinkles around the lips. And I actually think personally we should talk a little bit about some of the fillers that we like using for lip volume. But I would say I've injected a lot of fillers into the perioral area, meaning around the lips and into those fine lines. And I really say RHA Redensity is that is the best filler I've ever used in that area. And there are other thin fillers, but, patients are bothered by these fine lines around their lips. But I say, this isn't a lip augmentation filler. This is a fine line wrinkle filler, and it works fantastic. So Dr. Shtraks, tell me a little bit about some of the fillers that you like to use for the lips and why. And what would lend someone to get, or that you would use one filler for one patient and a different filler for a different patient?
So I will say that the majority of patients that I see are looking for a more conservative lip volume augmentation, just based on the practice and based on kind of my patient population. So I personally find myself gravitating towards Restylane Refine for most of the lips that I
used to say it was my mature lip.
For the mature lip. And frankly, I have Restylane Refine in my lip as well. I think it's a very soft, natural looking filler. It's not shape shifting or anything like that. It's really just kind of like enhancing what you have. RHA Redensity, I agree with you. I like that for perioral lines and wrinkles. It's really the only one that I have been using, and I think it really makes a very natural looking result. Sometimes for a younger patient or someone who's looking for like more definition, I'll use Restylane Kiss. I'm a big fan of the Restylane products for like the filling of the red lip itself.
Gotcha. So that's important to know, like we've had a lot of training. We understand how these fillers react and how they behave, but different fillers do different things and they behave differently in the lips. So in general, the higher the hyaluronic acid concentration or the more stuff that's in the filler, more hyaluronic acid, it pulls more water. So some of the fillers, particularly that have very high hyaluronic acid concentrations, swell a lot more. Yeah. Some patients want that. They want like a more puffy lip. And then some of the Restylane products tend to be a little bit lower so they don't pull as much water. But, what I tell patients is, I think this is important. A lip can only hold so much filler. And what we're seeing now is like everyone's coming in and they're saying, I have migrated filler. And I think that's like kind of like a misnomer. The filler isn't necessarily moving from one place to another, but the lip itself can only hold so much filler. Yeah. And when you exceed that, then it starts to spill over into the surrounding tissues of the lip. And that to me that's filler migration, right? When the lip can't hold anymore and it's now exceeding its boundaries and starting to move to other areas.
I also too think that some, like you were saying, some products hold a lot more water, so they swell more. I think that when those products are used, a lot of times that water pull is confused for migration.
Right.
So your actual product is holding so much water and it blurs the border of the lip. And instead of the upper lip, especially having that nice little slope, it gets totally, it just doesn't look the same. Yeah. It doesn't look right.
It's so funny you say that because like, I will say that's the one thing for me personally, again, and I don't inject a lot of lips, but I can tell from, I used to, and I can tell right away if someone's had lip filler because the lip should have, a natural slope. I say like a ski slope in that upper lip, and it should come up to a sharp border. When that has been altered and now you've got like a curved down area, that filler has been put in there and maybe sometimes a little bit too much.
Yeah, or the wrong point about like lips being able to only hold so much. I think it's really important to explain to patients, like not every lip is going to hold 1.0 cc's of volume, right? Like that doesn't even make sense. So we know that lip filler is meant to go in the red portion of the lip, of course, unless of course you're treating perioral lines, but it's supposed to go in the red part of your lip, but the dry red part of your lip. So that's a finite space and it's a potential space, right? Because you've got your surface and then you have the muscle underneath. And so it doesn't make sense that everybody would fill and take 1 cc of volume. So in my view, like when I'm treating a patient, I will say like, what is your goal? And can we achieve that goal with 0.7? Maybe. And if we're looking for a goal and not to just use the whole syringe, right, we may only use that 0.7 because at the end of the day, it won't matter if you squeeze another 0.3 and you just want the result that you want. So that I think it's important to have that conversation with patients because once you overfill, it does take the path of least resistance. It's either going to go into the white lip or, the skin color lip or the mucosal lip. Neither of those is great. And once you have that, then you're going to have to dissolve and start over.
And once you said this to me, once you create those pathways of migration, they're there.
It's so hard. Yeah. Once you have that, like those pathways where it finds that path of least resistance, you can dissolve them and then come back and then you try to be conservative and put a little filler. Sometimes it finds those same pathways.
Yeah.
Right.
Yeah.
Learned that the hard way.
Yeah, we've all seen it.
And no one likes to have their lips dissolved. It's
Right.
it's not only is it painful in the moment, but it's also
devastating.
It's like
Yeah.
a shock,
Right.
when,
And then
when
they
you
have
lose
to
all that
wait,
volume.
and then they're
So-
texting you, "Can I come in early?"
But I think that's important though, to like, at least when I'm seeing patients and they're, you don't like what's going on, they don't like what's going on, and you really need to start over. It's not the right thing to put good filler after bad. And sometimes it's best to just get rid of it, let the lip relax, and then come back and do the right thing.
Totally agree.
Right. So, Lily, tell me some of like the common myths that we see with lip filler and how we're, combating those myths every day.
I mean, I feel that we just touched on the biggest one, that it's always going to migrate. You look on TikTok, you look on Instagram, everyone's like, if I get lip filler, it's going to migrate. I feel like that's the biggest one. I'm trying to think of like other
You
ones.
know what the interesting thing is? This has been like, well, last year, this is our first podcast of 2026, but last year was a rough year actually for
fillers.
filler in
Yes.
general, and they were
Yeah.
down. And I think the way that filler is going to make a comeback this year is that it's not necessarily about more filler, it's about better filler. It's about using it more precisely in the correct area and using the right fillers in a smart, intuitive way instead of just pushing more filler to the patients. And I think knowledge for the patients, knowledge for the injectors, and for the companies, just like actually marketing that,
Yeah.
I think is going to kind of raise all ships in this industry.
And I feel that we have to be a little bit more assertive as injectors as well, because it's intimidating when a patient comes in and they're like, well, I read this and I did this. Obviously, we know that we're the professionals, but sometimes a patient needs structural support. Sometimes they need 2 or 3 syringes to prevent like the downturn of the lip, or to prevent like the little shelf that a patient could get. They might need like some cheek filler, chin shadow, to kind of make their lips look good. Sometimes you can't just treat the lips. And if a patient's coming in only wanting lip filler, they're like, well, I didn't want my cheeks done, or I didn't want my chin done. It's a little intimidating, but we just have to kind of trust our gut and know that we know better than the patient. Because these patients come in and they think they know everything with, social media. And just even trusting that, okay, I'm going to put 0.7 in the lips and not a full syringe. And they'll say, well, what are you going to do with the other 0.3? I'm like, well, the 0.7 is your full treatment.
Right.
You don't need that. I mean, sometimes we can do it like a little bit like around the mouth if it's a correct filler. But yeah, I've had a lot of patients ask, well, can't you just do a half syringe? I'm like, well, I might need more than a half syringe. You have to purchase a full syringe.
Right.
So just kind of being a little bit more strict with patients as well, because sometimes all the time they don't know better. We're the
Yeah, it's like
professionals.
results-based treatment instead of
Yes.
volume-based treatment.
Exactly,
Like,
yeah.
what are you really coming for? Like, do
It's
you need
the-
to get every...
It's the filler, not the filler, right? It's the person
that
injecting.
does the filling.
Right.
Yes.
So
Yeah.
we're trying to
yeah,
like base it, based on outcomes.
Right.
And, they're paying for a lip filler treatment. That lip filler treatment might be half a syringe,
Yeah.
might be 1 syringe, might be 1.2 syringes, and you guys all know the way I deal with my practice in this office is if someone needs a little bit more, right? A little tweak, maybe they'll come back at 2 weeks and they're like, I just could use. We're happy to like open up that extra syringe and treat them to get them the best result, because that's what they pay for. They pay for you guys doing the right thing for the patients.
Yeah, definitely.
So
Another thing to keep in mind too, the only fillers that actually come in a half syringe are Restylane L, which in my opinion is not appropriate for lip tissue majority of the time.
interestingly, I do agree with you, because
I
it's
know what
more
you're
of a
gonna
strong
say.
structural filler.
Yeah.
And not as like soft and mobile. And this is like, again, a very mobile area. However, Restylane L is approved for
I
the
know.
lips.
It's just personally not
Yes.
one of my go-tos. And then you have Volbella, which I mean we don't carry in our office for
Right.
for a
I think
myriad
there's a
of
reason
reasons.
that they don't come
So
in half syringes.
yeah, I mean it's not like every filler comes in a half syringe.
Right.
Just I feel like people don't know that.
So, let's say, Lily, let's say a patient comes in and says, I was on TikTok and I saw like this technique, and I want you to do that. Why are some techniques like not right for each patient, or like the Russian lips, or like, why do you have to, evaluate each patient to make sure that you're doing the treatment and it's not cookie cutter?
Yeah, I mean, some patients that might have a strong vermilion border, I don't need to do the Russian technique on them because they already have a strong vermilion border. You just need to fill the pink of the lip and just add a little bit more volume. You see like the keyhole, and they put like the string down the middle of the lip. Yeah, I'm like, what is that? Or like you see them taping around the lip. I'm like, what's that supposed to be doing? The Russian technique, I feel like looks so aggressive, but it's also just creating a really, really defined border that sometimes borders on like looking fake and looking overdone. But you just have to assess the lips. Sometimes they don't need that much structure. Sometimes they just need a little bit more of a Cupid's bow, and they need their lower lip filled more than their upper lip. Every patient's different. So I'm like, stay off TikTok. Like, I don't do that. Or like, I mean, you're seeing, like the Swedish lip now, I think. Everything has like a name. Everything has a name. So I just think that it's trusting your gut and just saying, this is your anatomy. I'm going to add a little bit more definition, or I'm going to fill it in, fill in the volume a little bit more. But I don't know. I just would be like, let me do my thing. You came to me for a reason. You've seen my before and afters.
Exactly.
Just trust me.
Nice.
Yeah.
All right, so let's kind of let's move on a little bit, and let's talk about kind of neuromodulators in the lip, and certainly one that's making a little bit of is at a high kind of right now, and a lot really talked about is the lip flip. So Julie, tell me a little bit about what it is and what's the point of doing this procedure.
So the lip flip, unlike lip filler, is not adding volume to the lip. It is treating the orbicularis oris muscle, which is the muscle that's, makes up the lip. And it treats an overactive orbicularis oris. So if you have the type of smile where when you smile big, you kind of, what I would call lose your upper lip, right? Like your upper lip curls under. You're a good candidate probably for a lip flip, because what it will do is it will relax that muscle so that with movement and smile, you're not curling in so much. You're not losing that lip. And so as a result, what you can get from it is more red lip show, which is a goal for most people. And for some people who have a gummy smile, it can also be helpful for actually covering the gums a bit. It's distinct from gummy smile Botox, which is sort of a different targeted muscle group, but it serves the purpose of covering a gummy smile for some people.
So is it really flipping the lip out, or is it preventing the lip from rolling in?
So it's preventing the lip from rolling in, but it is, I mean, I think it's doing both, frankly. Like, and I personally have it done. Like I get it done every 3 to 4 months with my typical Dysport. I have one of these lovely ladies do it for me. And we use Jeuveau on my upper lip. And it, for me, has been the biggest game changer in my upper lip, like red show. I have a little bit of filler in my lip, but my lip is naturally more thin, and it's very overactive when I smile, or it used to be. And not only has it prevented curl-in, but also you at baseline see more of my red lip kind of always. So it is interesting, though. It impacts everyone so differly.
Yeah.
Like there are some people that like...
I don't the lip flip at all.
You mean in yourself or in general?
I can't stand it.
So, well, how many like units do you use typically when you're using a neuromodulator, and what are your favorite neuromodulators for this procedure, and why?
So I think personally, and as an office as a whole, we're definitely a little bit more conservative with the amount of units that we do for a lip flip. I know some people, do 15 units, which I think is a little crazy, because you need the muscle around your mouth to do everyday things. So I don't think it's appropriate to totally immobilize it. So typically I do 2.5 units per side. So 5 total, conservative. With that, it doesn't last very long.
So what do we tell patients about how long it lasts, and where do you do the injections?
So I if someone has lip lines, I'll do 4 points.
Okay.
So I'll do 4 injection points. If someone just wants a lip flip, I typically just do 2. What was the second part of that question? Sorry.
How long do you tell them that it lasts?
Oh, so I mean, it typically lasts a little bit less time than their upper face toxin. That's
I normally say like 6 to 8 weeks.
yeah.
Yeah. I always tell people like it's a narrow therapeutic window, meaning like if you go any lower than 4 to 5 units, it's really not going to last. If you go much higher, you're going to have more of the functional issues. So you're kind of like, in my view, stuck in this 4 to 5 unit space.
Right. Which is not a lot.
Which is not a lot. No, it does not take much.
And you find if a patient loves it, it doesn't last long. And if a patient hates it, it like lasts a full 3 months.
Yeah.
Yeah.
But it's a pretty easy, safe experiment, right? Like if they don't like it, worst case scenario, it's worn off.
That's
in
the
a month.
best
Or if
thing,
it says-
toxin goes away.
Yeah.
We tend to use in this office. We tend to use a lot of Juvo
Yeah.
for lower face tox because again, this hasn't been proved, but I can say anecdotally, I think it's got a very tight diffusion. Again, I can't say that there's been a study showing that, but I can say just in my personal experience, I think it has a very tight amount of diffusion. So when you're trying to hit small muscles in the lower face, certainly around the mouth, Juvo does a great job of getting at those
I feel like it
fine
kicks in
muscles.
pretty quick as well. So if a patient wants it for the weekend or something, you're definitely noticing a little bit of a result.
Yeah, and it's
Quicker.
substantially less expensive
Yeah,
than
for the patient.
than Botox.
Yeah.
So
Yeah.
why not?
Dr. Shtraks was mentioning some of the functional things that can happen if you get too much.
Yeah.
Lily, tell me a little bit about some of those things that can happen.
Well, I personally had this happen, but
I was
With the
making
conservative dose.
with
too.
the conservative dose. So
I was
had,
making fun of you for a while.
If anybody wants to look at the last couple podcasts, you saw that my upper lip did not move and I was probably slurring my words. But I've had it before and I've never had that happen. It's just, it's the name of the game. It happens sometimes, but sometimes you feel that you can't smile as much. You just feel, for me, it was more that the medial part of my lip wasn't moving and then the corners were moving. And my lip, I don't know, it showed a lot more and it was just, I had no movement with a very, very conservative dose. And I feel like that's the biggest thing for patients. If they're big straw drinkers, they're like, I couldn't sip through a straw and it really bothered me, or I was trying to put on my lipstick and I couldn't purse my lips, or I couldn't go like that.
Speech
That is
with plosives, so P
Yes.
and B, where you need to actually create
Yeah.
that
Yes.
pursing. It's very
and
hard
you're
when
fighting
reaching
because
in.
I had a couple of patients were like, what did you do? I'm like, nothing. I did nothing. I'm trying to talk and do consultations and I couldn't say my P's and stuff. But I'm going to do it again because I liked it last time. So we'll just try it, with a 4-point injection instead of a 2. But I feel that that's the biggest thing. But I always ask, are you a big straw drinker? Do you purse your lips a lot? Sometimes that's good because it'll help to relax the muscle and you won't get lines if a patient has lines on their lip. But you just have to let them know that it's going to be harder to do those things so they don't come back and say, oh, I couldn't drink through my straw and I was slobbering all over myself.
I personally find that those side effects don't last the whole treatment
Yes,
duration.
yes.
So it's
No.
the first week or two where you're sort of compensating.
Yes,
So
definitely.
it's just kind of getting through that.
And then it gets more subtle and then patients love it and then it doesn't last as long and then they're coming back asking for more.
Yeah.
Yeah.
So let's move on to a little bit of some of the surgical lip things. So I'll let Dr. Shtraks really start here, and I'll call if a patient comes to me for even a facial rejuvenation surgery. You just have such great expertise in this area that you'll come in at the beginning of some of even my facelifts, and you'll do a lip lift on these patients, but. What is a lip lift and who's a good candidate, and tell us a little bit about it.
All right. So first of all, I love the surgical lip lift. I think it's a great procedure. There's definitely a place for it in facial plastic surgery, and there's a patient for it. So for those who are not familiar, the surgical lip lift is the surgical shortening of the lip. One thing patients don't always understand or realize is that the lip is not just the red lip, it also involves the skin. So the distance between the base of the nose and, the bottom border of the lip is the lip. So when a lip becomes longer over time, starts to cover the teeth, you start to lose some of that red lip show. These are all things that would make somebody a good candidate for a surgical lip lift. So the lip lift is performed, at least in my hands, it's called the modified bullhorn lip lift. So the incision for this lip lift exists in the crease between the nose and the upper lip. And what we're doing is using careful measurements to determine how much skin and soft tissue we're going to remove, and then closing it. There's some more steps in between, but ultimately what happens is you're decreasing the length of the skin portion of the lip, everting the red lip so that you're seeing more of that, and oftentimes, depending on how much you're removing, exposing some upper teeth, which we perceive as youthful and feminine. So these are all
also
good
based
things.
on the patient's wishes.
Of
too,
course,
right?
of course.
And so, like, somebody might say, like, I don't want, incisive or tooth show, and some
Sure.
people might want it.
Right.
But, it's interesting you call it the modified bullhorn. It is called that because if you ever, like, seen, like, the Texas Longhorns logo with, like, the long horns, that's, like, kind of what the excision looks like, and it falls right in that crease with a nearly imperceptible scar afterwards. And, yeah, I mean, that is really important, but it's important how much you remove.
Yes.
But it's also important how much you leave.
Yes, that's the most important,
So
actually.
tell us a little bit about that.
So when I'm seeing a patient for a lip lift consultation, I tell them I'm looking for really three things that make them a candidate. One is, do you have a long enough upper lip? So you have to have some skin lip. Like, you can't just have your nose going straight to your red lip, of course. So typically you need to leave at least 11 or 12 millimeters behind, which means you have to have enough length to make that worth your while, to make any excision worth your while. So one is lip length. Two is upper tooth show. So in a patient who has a long lip but already has upper tooth show, you have to be careful. You may not want to expose more upper teeth that you can make them too toothy. So that may make them a candidate or not. And then the last thing is, you have to make sure that the patient will be able to close their mouth or not lose function. So sometimes patients who are a little bit older, when they let their mouth fall open, you can see their bottom teeth, which suggests that they have like weakness of their mentalis muscle, so which is the chin muscle. So you want to make sure that they're not going to have to strain to close their mouth after. If you meet those three criteria, right? You have a long enough upper lip, you don't have too much tooth show already, and you don't have a weak mentalis muscle, you're a candidate. But then there's a kind of wiggle room about how much you're going to remove. And we're talking about millimeters here. So usually,
What's your average amount of skin that you would remove?
I would say probably the average amount of skin I remove is 6 millimeters. I'm usually removing between 5 and 7 millimeters. There are some sort of like general guidelines, like, if you remove 5 millimeters, you're probably going to get a millimeter more of tooth show, 1 to 2 millimeters. And so you can't like fully rely on that. Every patient's a little bit different, but you kind of can follow those guidelines. And I really try not to take people all the way down to the minimum residual lip. Like, it's just, I don't like to kind of cut it that close.
Yeah.
So I have a question. Do you have an age limit for patients? Because I know people in their 30s that would definitely be a candidate, but can you do it too early where you would need another one? Because as you continue to age, the lip will continue to elongate.
So I don't have an age cutoff,
Okay.
Whether too young or too old for this procedure.
Yeah.
There are patients who just genetically have a longer lip. There are patients who have been getting lip filler for years and years, and it has weighed their lip down. That's kind of an extreme example, but it can happen. And so this is something that's become popular in younger patients also. I have not, repeated a lip lift on a patient so far in my practice, but I wouldn't see a problem with that if you had to. Like, if in decades from the index procedure you're doing or revision, I think that's totally fine and doable and appropriate. It does tend to be a procedure that I do more often in patients who are, noticing it elongating with age. It's
Yeah.
very common to do with other facial rejuvenation procedures. As you
Yeah,
mentioned.
I mean, it's interesting that you say that too, because it's not like they're growing skin, right? It's just like an upper blepharoplasty.
I was gonna say
You
it's more
might
like a
do an
bleph.
upper bleph on someone,
Yeah.
and then they continue, like their brows continue to
Yeah.
get a little bit lower, and they get re-hooded over 10 years later.
Yeah.
It's not like they grew more skin
Yeah, they
there.
just
It's not like you're
continue to
growing more skin,
age.
Right.
but that can still elongate.
Right.
Yeah.
With other like volumetric structural changes over time, they
Yeah.
can start looking longer again. But I haven't even encountered that.
Yeah.
Yeah.
A couple other things, so what do you do, like if a patient comes in and they want a lip lift, but they have a lot of filler? Like, what is your your outline? Like, when do you dissolve it? Do you dissolve it? Do you do a lip lift with filler in? Tell me a little bit about
I
that.
always have patients dissolve their lip filler prior to the surgical lip lift. I like to dissolve it at least 2 weeks ahead of time because I want it to really have had a chance to dissolve. As Sarah
And the tissues to
Right,
actually have
right.
time to rebound a little
Right,
bit.
exactly. It's just to reach a new equilibrium. As Sarah mentioned before, you will see. So what I do is I take a picture, preoperative photos with the lip filler in. Then I dissolve it and take another set of preoperative photos, and then I take the after photos. And if you look, what you'll see is that oftentimes with the filler in, it's longer. Like the lip looks honestly significantly better from a height standpoint oftentimes after the filler is dissolved,
Yeah.
but the lip is small and patients obviously don't like that. So I do think especially if we're talking about millimeters, it makes a difference, to get that filler out of there. Not to mention that the lip will swell like crazy if you have filler in it. It swells like crazy anyway after the lip lift procedure for a short period of time. But if you have a hydrophilic filler in there, it's obviously going to be more extreme.
And tell me a little bit about, so it's not always just the modified bullhorn lip lift, right? Sometimes patients, depending on what's going on with the corners of their lip, might need what's called a corner lift.
Yes.
So tell me a little bit about that, and how do you make that decision if a patient needs, you did someone, and I was doing a facial rejuvenation procedure on them around their eyes and their brows, and you came in and did a lip lift, and you did a unilateral corner lift on the patient. It looked awesome, but what do you pick out that says, yes, that looks good or not?
So a typical bullhorn lip lift is a lifting of the subnasal lip. So the lip, you can only lift as far as the nose goes, right?
The
And
base
so
of the nose,
the nasal base goes. So if someone has a narrow nasal base but a wide commissure to commissure distance, they may be someone who's going to need a corner lift. If you have a kind of wider nasal base and a smaller commissure to commissure distance, unlikely to need it. There are measurements that you can do to truly assess whether or not the slope of the lip is going to be too steep if you don't include the corners. But usually you can tell clinically. And what I mean by slope is that what you don't want to do is be lifting the central lip and have the corners be low.
Right, because that can actually look like...
It can look very exaggerated and unnatural, and that's obviously an undesirable outcome. So you really want to be assessing their nasal base to commissure kind of ratio. And then there is a measurement system where you can determine whether or not your slope is going to be too great. I think it's important to understand that the only purely vertical vector of lift is centrally, and as the farther out you go, it's becoming
slanted.
More slanted, and you're getting less of a lift. So you really want to make sure that you're leaving people with natural slopes, and so that they look, natural, unoperated, rejuvenated. This should be a subtle, beautiful result.
And one other thing that I will say that a lot of people don't know is that if you are doing this procedure in an isolated manner, you do it right in our office under local anesthesia, which is pretty awesome. It takes you about, an hour and a half or something, an hour?
I usually will have people come in. We have a procedure room here, obviously, as you know, and I will offer patients medication to help them relax or take the anxiety edge off if they're nervous. And to keep them comfortable, I will do a dental block. So I'm actually, like you go to the dentist, I'm doing 2 injections under each side of the upper lip, and that makes this whole area numb. And then I'm able to numb the area directly and if you get a good block, it doesn't hurt at all.
Right.
And so it's a pain-free procedure for people. And then, they walk out of here an hour and a half later.
And what would you say the downtime is? Because when I talk to patients and I show them, immediately after, it looks a little scary because you see that the patient's like stitched up and they're swollen. But I try to explain to them it's not a bad downtime.
This is how I would explain the downtime. So immediately after the procedure, the patient's going to have tiny little black stitches right in this area here in that bullhorn configuration. Immediately, it's going to look a little exaggerated and maybe a little crazy. I always warn patients that the next 3 to 4 days, they're going to look crazy.
Yeah.
And I overwarn people because they're going to look like some people look like they got stung by a bee, like their lip is really swollen.
They're going to say, what did I do?
Short. They have a what did I do moment. But if you pre-counsel people about this, they know it's coming and they're not worried. I usually take the stitches out at about day 5 or 6.
Okay.
You really don't need to leave them in much longer than that. All of the heavy lifting of the surgery is done with the deeper stitches. So the skin stitches are just to make the edges look perfect.
Kind of like with facelift surgery, right?
Okay.
Like
tension-free.
I tell people that it's a muscle surgery, not a skin surgery.
Exactly.
So we just kind of trim off the extra skin that kind of like runs around it, but it shouldn't be like a tight closure.
Right.
Like you said, tension free, you just trim off the extra skin and it lays like the skin edges are kind of kissing.
It should look closed before you even do superficial stitches. So, but what I will say is you can't wear makeup on that incision for 2 weeks. And so
that's
that
good
is a
to know.
factor to consider because that incision will be visible for the first couple of weeks. It does take several weeks to even months for it to fully fade, but when it does fade, it fades beautifully and is
you can't tell.
So.
Okay, it's good to know.
And then, just tell me like some of the things, Lily, when you're talking about seeing a patient for lip filler, like what's your go-to about how much do you normally inject at each time on average? How often do you tell these patients that they're going to need it? What are the questions? Like, do you give them numbing blocks like Dr. Shtraks was saying when she does a lip lift procedure? Do you do numbing blocks for injectables? Tell me a little bit about some of that stuff.
Well, I will numb them topically. I don't normally do a dental block. And I remember you saying this, you need them to express. I need them to be able to smile. Like I'm that person that
if they were numb, if you did a numbing block, like it's great when you're doing a lip lift when you've predetermined how much skin you're actually removing. But like you want them to look good when they're talking, kissing, chewing, smiling, right? And so if they're blocked and then you're like smile and you're like, it's hard to see that. I don't think anyone in our office actually does, but like you would be surprised how many people do.
And I'm telling my patients,
blocks.
and it's hard for them to smile even with the topical numbing.
Yeah.
Normally I'll do about, I think what Dr. Shtraks said, like 0.7 to 0.8 in a lip. I rarely ever do a full syringe in a lip. But
do you like to use the syringe as is, or do you put it into small like?
I started putting into smaller syringes. I feel that I have a little bit more control. I do a lot of refine as well, so I find that it's very easy to push with the smaller syringe. If I do something like a KISS or an RHA2, I'll keep it in the normal syringe. But I feel that doing 0.7 to 0.8, you get a really pretty result. The patients tend to be really happy with it. But I feel like doing more, you're kind of, the lip probably can't handle it. And then I feel that you're kind of chasing swelling at that point. Like normally I'll do 0.2, like all around. And then I'll have them express, make sure that everything looks even. And then if they're wanting a little bit more, I have a little bit more to play with. But yeah, I feel that, like you said, the topical numbing, I definitely want them to be able to express, but I rarely do a full syringe. I just did a full syringe in a patient who had very big lips and could handle it. It almost looked like I didn't do any filler because their lips could handle it, but that is very, very rare.
I think our office in general and like our aesthetic is like we're conservative and people don't come to us for these like huge lips. No. They come to us for balanced, beautiful, conservative, intentional lips.
And when someone does come and they want the really big lips, or they say, I want it to look straight across when I smile, it gives you a heart attack. And you're like, no, I can't do that.
It's
no,
so
thank
rare
you.
That we see people asking for a lip that doesn't really jive with our aesthetic. I I think you attract the kind of patients who are desiring an aesthetic as what you put out.
Yeah, definitely. I agree with.
So I think a question that we get a lot is, a patient maybe comes in and they have a little bit too much filler, or they don't like maybe the filler that they have, whether it's too much or not, but they're worried about getting their lips dissolved. We see that a lot because they're like, oh, it's going to stretch out my lips and then I'm going to have baggy lips afterwards. What do you see when a patient comes to you and wants some dissolving? What actually happens to the lips upon dissolving? How do you counsel that patient?
So I just tell them you would need an insane amount of filler to actually stretch the tissue, more than anyone would ever do. And your lips aren't going to be baggy once we dissolve them. They're just kind of go back to how they were. Usually with one dissolving treatment, that's not enough to get rid of whatever filler is there. So I usually do 2, sometimes 3 if they've been getting filler for years and years and it's different products. It depends on what kind of product.
Filler is in multiple planes. It's not like you can just put hyaluronidase, which is the dissolving agent, in, and it's just going to like find the filler and it's going to be gone, right? People are injecting submucosally where you should be putting it. People are injecting in the muscle. People are injecting, at all these different areas, and sometimes it does take a couple treatments to get as much of the filler as you can out.
And I also kept seeing this trend on social media called micro dissolving, which was infuriating because that's
good thing
just,
I haven't seen
yeah,
it,
it's just
I would
not
go crazy.
It's not how it works. I mean, you did say that hyaluronidase doesn't necessarily find filler in every plane, but it will find whatever filler it can. That's its job.
If it's next to it, yeah, you can't, like, if someone's like, okay, I want this dissolved, but not this. Like, if you put hyaluronidase in it, it's going to find the filler.
Right. So this whole micro dissolving thing, like, let's just dissolve a little bit to get you where you want to be. I mean, really the only control that you have over how much is dissolved is how much dissolvent you use.
Right, exactly.
So, I mean, you can do little bits of it, but you can't pick and choose what leaves and what stays. Yeah. So, I mean, swelling is normal. You're going to be swollen for about an hour, and then most of it goes down. And then typically by the next day, it kind of is what it's going to be.
Yeah, and that makes sense because, hyaluronidase itself has about a half-life of about 24 hours. So even when I'm injecting, like, dissolving other areas, I said, you'll see some, but like tomorrow, it's going to be even a little bit more dissolved.
The interesting thing about dissolving lips compared to dissolving other places is that in the office, the lips look bigger.
Right.
Yeah.
So like
they're like, what did you do? Oh
yeah,
my God.
So I just prepare patients for that. Like, you don't get that same instant gratification that you do when you dissolve, say, teardrop.
Yeah.
And it's crazy. I guess 5-ish years ago, we kept Hylenex in the fridge in case of an emergency.
Right.
You didn't really touch it other than that. Now it's like, knock on wood, thank God, we don't ever have to use it for an emergency. We use it so much to dissolve, like even for, your pre-op patients, you guys will dissolve filler that is going to interfere with surgery, that kind of thing. Or we're dissolving lips, or we're dissolving filler that just looks poor or isn't right in the wrong plane. So it's interesting how much of a shift there's been with, it used to be a good thing that you weren't using your Hylenex.
Well,
now
I think that, the interesting thing about that is that people are coming to us because we're the experts and,
plastics office.
They're asking us to like kind of fix and tweak, filler that they might be not super happy with. So we're lucky that we get to see those patients.
Yeah.
It just kind of
a lot of responsibility.
Yeah,
too.
it does. It just kind of says that people trust us that we're going to do the right thing, and it's hard to fix, to play the cleanup guy and fix other people's not necessarily messes, but situations like that.
Yeah, definitely.
So. Well, with that, I will say thank you so much to my guests and especially our special guest on this episode, Dr. Shtraks. But thank you too for listening to this podcast. As always, we are inviting you to give us some feedback and tell us what you want to hear about. Thanks for listening to Beauty in Bloom. We'll see you next time.